We will invite all the doctors to visit our website. Now, without any further delay, I would like to hand over the session to Dr. Juhi Shah ma'am. But before handing over, I would like to introduce her. She is a consultant pediatric hematology oncology at PMT at Fortis, Mumbai. And we also have two eminent speakers, Dr. Ruchira Mishra. She is consultant pediatric hematology oncology and PMT at SRCC Children's Hospital, Mumbai. And we also have with us Dr. Sachin Jain. He is additional director and HOD, hematopathology and molecular oncology at Fortis Healthcare, SRL. So over to you ma'am.
Yeah, thank you so much. So today's session actually is mainly focused on the most common pediatric malignancy, that is acute lymphoblastic leukemia, and the challenges we face while managing these patients. And we wanted to highlight the clinical aspects as well as the pathology, which is a most important and cornerstone of managing these patients, right from diagnosis to treatment and later on when we follow them up. So without further ado, I'd like to first call upon our first speaker, who's Dr. Ruchira Mishra, as introduced. She's consultant pediatric hematology and oncology and BMT at SRCC Children's Hospital. She'll start the session today with the clinical aspects. Over to you, Dr. Ruchira.
Thank you so much, Dr. Juhi. I will start. So today's topic, as Dr. Juhi mentioned, is the commonest pediatric cancer that we see. This is acute lymphoblastic leukemia. I will start off by telling you a story. This is a story about Barbara Bowles. It is in the summers of 1968 that Barbara, a young 5-year-old girl child who otherwise was a very happy-go-lucky child, going to kindergarten, playful, spend the whole day outside. Her father noticed that she was now feeling very, very tired, had stopped or was taking very frequent rests, had stopped actually going out to play, just wanted to play in the backyard. And then gradually that stopped as well. She started getting a lot of fevers and had a lot of nosebleeds. And then the father noticed that she was getting a lot of bruises as well present. And over the next few weeks, her energy just kind of sapped out of her. So the dad was very concerned and he took her to a pediatrician in 1968. At that time, he ordered some blood tests and then gave them what sounded like a death sentence to Mr. Bowles, that the child had got blood cancer or acute lymphoblastic leukemia. What he did then was something that we pediatricians love, or we pediatric oncologists love, and he took her to a specialist. He took her to a doctor called Don Pinkel. Don Pinkel in 1968 was starting out and he was very, very passionate about treating children with cancer. And he had designed a treatment protocol for them, knowing that most of his children may not actually survive, but he was willing to give it a try. And from that start, and that's what Don Pinkel says, from the start, hope was always my theme. He was hopeful that one day he would find a cure for pediatric cancers. Don Pinkel was the first director of St. Jude's Hospital. St. Jude's is one of the premier institutions for pediatric oncology in the United States. And even today, they churn out the most path-breaking treatments for pediatric cancers. And that's how treatment for acute lymphoblastic leukemia has actually evolved, where somebody who's passionate about treating them gives them the treatment, sees the change that is happening, and then evolves the treatment further to cure more and more children over it. So when we talk about acute lymphoblastic leukemia, for a general pediatrician, what does that actually mean? We all know that our blood cells arise from the blood stem cells that is there, and that then differentiates into the myeloid series and the lymphoid series. The myeloid stem cells will then form the myeloblasts, and that will mature to form the granulocytes, which are the different components of eosinophils, basophils, neutrophils, and all, and also form the red blood cells and the platelets. whereas the lymphoid series, the lymphoid stem cells will form the lymphoblasts for you, which will again differentiate to form the B lymphocytes, the T lymphocytes, and the NK cells. All these cells help to fight infections in our body. When these go rogue or they start multiplying without any control is when we start developing acute lymphoblastic leukemia. So if you have cancers of your lymphoid series, that's when you get acute lymphoblastic leukemia. It could be your lymphoid stem cells, or it also could be the lymphoblasts, which are the common that we see. What are the risk factors? Which are the people or children who will develop acute lymphoblastic leukemia? Again, those who've been exposed to X-rays before birth or have been exposed to some form of radiation prior. Some of them may have actually been treated for a different cancer prior, so past treatment with chemotherapy or with radiation therapy, or have some risk factors, genetic conditions like Down syndrome or neurofibromatosis or Fanconi's or ataxia telangiectasia, familial syndromes like Lee-Fraumeni syndromes. All these kind of predispose you to developing acute lymphoblastic leukemia. There may be some constitutional mismatch repair deficiencies also present, like a dyskeratosis congenita or some other deficiencies, which may lead to the growth of or development of cancers later on. But what we also know is, in spite of having everything normal, when you do develop acute lymphoblastic leukemia, there are certain changes that are happening in the chromosomes or genes, and that those changes are the ones which lead to the formation of these cells which rapidly divide and cannot be killed off by the normal immune system at all. So how does one diagnose that a patient may have leukemia? What we really need from pediatricians is to be able to have your eyes and ears open and to have a very low threshold for suspecting pediatric ALL when you see these patients. They come in with a short history of fever. The fever may not be very long. It may not have been going on for months. It may only be for about a week or so, not responding to treatment or responding to treatment, but then recurring again and again. Easy bruisability, bleeding, or may actually have bruises or petechiae all over the body. What are petechiae? Petechiae are these fine pinpoint dark red spots under your skin, which are because of subcutaneous bleeding that is happening. More often than not, the child will be complaining of weakness, looking very pale, feeling tired, doesn't want to go out and play, has lost his appetite, spends most of his day in bed, doesn't want to play with his peers. That's what happens. Some of them may actually complain of bone or joint pain, or may actually complain of shortness of breath. That shortness of breath will be because of severe anemia that is there. You may also have parents coming in and saying that they have noticed that there are some lumps that the child can feel, lymphadenopathy in our terms, with the neck, underarms, or in the groin that they can feel, or an ultrasound may also have picked up lymph nodes in the abdomen. Some parents may actually say that when they feel the tummy, they can feel something in the tummy of the child, so which is hepatosplenomegaly for us. So maybe a small soft liver. Some of them may actually also develop splenomegaly, and some astute parents may also be able to tell you that that's what they are feeling. They may not be able to tell you splenomegaly per se, but they may be able to tell you that there's some growth or something that they can feel in the tummy as well. And you as a clinician, if you can feel these, then yes, you definitely have to think that this child may be having a hematological condition. So what would be your clues to diagnosis? If there's usually a short history, as I said, a short history of fever, a short history of bleeding or bruising that is present, there's usually hepatosplenomegaly, maybe a small spleen that is palpable, just the tip palpable, or 1 or 2 centimeter spleen, a liver that's palpable. Lymphadenopathy may be there, lymphadenopathy which is not responding to more than at least after 1 cycle of antibiotics. Please do not try and attempt to treat it with 2 or 3 or 4 lines of antibiotics. That is just not correct. If you think that 1 course of antibiotics has not helped, then either a lymph node excision or some other investigation to see what is the cause for the lymphadenopathy needs to be looked at. If you ordered a CBC, look at the CBC in totality, please. It's not just the HP, the TLC, or the platelet count that you have to look at. You have to look at what is the differential count that is present. What you may have is a normal a normal TLC, but a low neutrophil count. Or you could have even a high TLC or a low TLC, both may be present, but the neutrophil lymphocyte ratios would be disturbed. And if your lab flags any atypical cell or atypical lymphocytes on the peripheral smear, these are red flags even for us to say that this child could be having leukemias. As a pediatrician, please do not forget to look at the testes in boys, because acute lymphoblastic leukemia can actually affect the testes and you may get a painless enlargement of the testes. It could be unilateral, it could be bilateral. So having a unilateral painless enlargement does not rule out leukemia. In fact, in most cases, you will find a unilateral painless enlargement that is present. Painful enlargement of the testes is not leukemia at all. So it's painless enlargement and therefore often is not actually picked up unless examined by the pediatrician. And also the fundus needs to be examined in all our patients. A lot of our patients get leukemic deposits in the eye and they may complain with either vision loss or some visual disturbances that are coming in, or may even be asymptomatic. But if you do a good fundus examination, you will be able to pick up that there may be an abnormal deposit over there. So these are the clues to diagnosis. Then what do you do once you've suspected leukemia? What should you be doing? Before that, why should we actually treat leukemias? Well, as I said, in 1968, there was not a lot that they could offer to pediatric leukemia patients, and only about 10 to 12% of these children survived. But treatment over time in the last 50, 60 years has actually evolved. And now St. Jude's itself, this is the graph of St. Jude trials that have happened, and St. Jude claims that about 95% of their acute lymphoblastic leukemia patients will be cured of their disease, and they have an overall survival of more than 95%. When we talk about overall survival, what we actually want to say is if the cancer does not come back in the next 5 years from when you've started treating the child, the chances that it will ever recur in their lifespan is almost nil. So you're offering that this child will actually live to whatever lifespan that they have, destiny has chosen for them. For the rest of their life, they can live as normal human beings. We all pediatric oncologists have children that we've treated at 4 years of age, at 5 years of age, who are now 15, 16 years, going to college, some of them actually becoming doctors themselves, or having gone to choose whatever life they want to lead beyond that, living a normal life within society. So that is the reason why all pediatric oncologists want to treat leukemia, want to create that awareness for leukemia. Some of you may say that these are Western figures and India does not have that good rates. No, India is also evolving, and all good centers in India have survivals of between 80 to 85% for acute lymphoblastic leukemia. We may not have the same story replicated for acute myeloid leukemia, but the commonest cancer being ALL has a very good survival rate. And hence all children who are diagnosed should be referred to a pediatric oncology. There are enough of our tribe present in India today who will be able to take care of your child for you. And once the treatment is finished, hand it back to you to take over care for the rest of their lives. So please keep an eye out for signs or symptoms of leukemia and refer at the right time. What tests would you like to order when you think that this child has leukemia? A CBC with a peripheral smear goes without asking. Also ask for an LDH, ask for a uric acid, ask for a renal profile as well, because some of these kids develop complications just when we are starting treatment or before treatment. So all these will give us a guide to suspect or tell us that this child may need intensive therapy, or this child actually has what we look at or look out for is tumor lysis syndrome in our children. We need a bone marrow aspiration and biopsy to confirm the diagnosis. A lot of pediatricians often do the bone marrow aspiration and biopsy themselves, diagnose the leukemia, and then send it over to the pediatric oncologist. Just a bone marrow aspiration and biopsy in today's day and age is not complete. What we really need is a lot of tests, a lot of questions to be answered from that bone marrow specimen itself to be able to tailor therapy for that child. So what we we need is to be able to do the bone marrow aspiration biopsy ourselves, or you should have the ability to send this off to a good lab who will do these tests for you, give you the answers, and then with all those answers, you can refer to us. So what do we need from that bone marrow aspiration and biopsy? We need to know the flow cytometry, because this tells me exactly where the change is happening. Is this a pre-B leukemia? Is this a pro-B leukemia? Is this a Kala positive or a Kala negative leukemia? Which kind? Is it a B cell or a T cell? All these questions will be answered by that flow report. A lot of times we could have an AML and an ALL present, which is what we call a mixed phenotype acute lymphoblastic leukemia that may be present. The same cell may have features of both AML and ALL, which will make it high risk. And or it may have two different phenotypes that may be existing within that same patient itself. So that bone marrow needs to go for a flow cytometry to a good lab. In Mumbai, we have lots of labs, and every city in India has a good lab that you can send it to. So you need to recognize those labs and be able to send that bone marrow at diagnosis before you initiate therapy to those labs as well. We also need the bone marrow to go for cytogenetics and for molecular markers. A lot of our treatment is now defined by these cytogenetics and molecular markers, because we stratify disease as being standard risk, moderate or intermediate risk, and high risk based on these cytogenetics and molecular markers itself. So if the sample has not gone at diagnosis, it is often that we may be offering suboptimal treatment to the child and he may relapse later on. So to be able to give the correct treatment, we need these samples to go at the time of diagnosis itself. And we also need to do a lumbar puncture and send the CSF for malignant studies. Like I said, the testes could be involved in boys, but the CSF is also a site where the disease can actually go to, and they may be present, a CSF or brain disease may be present at the time of diagnosis, and we would need to tailor our therapy for that as well. So that CSF also needs to be done before we can start the treatment for leukemia as well. So what we would say is, once you think that the child has leukemia, refer to a center where all these tests can be done. Or if you have the facilities to do it at your center, then do everything in totality before you refer the child out. Don't do piecemeal testing as well. I want to stress on the cytogenetic abnormalities of ALL. We've actually been able to tailor our therapy based on that, and we can classify our children into three main groups. That is standard risk, which is children between 1 to 10 years of age, and those who have a white cell count that is less than 50,000 into standard risk, with a few abnormalities that may be present, and these abnormalities help to tell us what would be the whether to classify them as standard risk or high risk. High risk would be children who are either less than 1 year of age or more than 10 years of age, or children who've got a white cell count that's more than 50,000. Adults, young adults and adolescent kids also may have cytogenetic abnormalities, and the set of cytogenetic abnormalities seems to differ in these patients as well. And adults may have a completely different set of cytogenetics, but cytogenetics are present in more than 90% of our children. Abnormalities are present, and these do define treatment for our children as well. Sorry, my slide just stopped moving. So, as I said before, we have a lot of cytogenetic abnormalities, and this field is something that is actually changing day by day, and this is defining treatment for us. Cytogenetic abnormalities are present more in children than in adults, and some of these actually tell you that they may have a poor prognosis. Or a better prognosis. Children with hyperdiploidy or with more chromosomal abnormalities actually have good prognosis, and this may tell you that we may actually decide to reduce treatment for these children now, whereas those who have hypodiploid or low chromosomal numbers, that is 32 to 39 chromosomes, will actually have a poor cytogenetic, poor prognosis. And we have to think about new targeted therapies. If you have an IAM21, then that's a poor prognosis. And in our group, we often think about whether we need to intensify treatment, even to think about bone marrow transplants in first remission for these children. The common abnormalities that are used right now to risk stratified treatment are BCR-ABL, which is the Philadelphia chromosome, H21 translocations, MLL gene rearrangements. These are used to classify treatment for our children right now. These are all treatments or changes, mutations that are present in BALL, but TALL also has a lot of mutations, and we use those also to define treatment or to give them targeted therapies as well. We have JAK2 inhibitors that are coming in, some other targeted therapies that are evolving based on these mutations that we are finding in our kids as well. So therefore, having a cytogenetic abnormality and looking for one is very important in our kids as well. Another important aspect where flow comes into place is MRD. When we know what is the initial picture that our leukemia population looks like, we then use that to monitor the response to treatment. And that is by a technique called MRD. MRD initially used to be called minimal residual disease. Now we call it measurable residual disease. This can be done by different ways. In India, we have generally using a flow-based technology that is being used at the moment, whether it is a 6-color flow or an 8-color flow or a 10-color flow, depends on your labs. But this is forming the baseline for our treatment. All centers will be using MRD now to do a risk assessment, to do a response assessment at the end of induction and then at time point 2, and then use it to change therapy if it is required. So MRD testing is a very important component of therapy as of today for all of us. And this can only be done if I have a good initial flow done so that I can actually pick up the abnormal clone right at diagnosis itself. So all these newer testings have actually helped us to get a better classification of ALL. We are now differentiating between T and B ALL. We're also having a diagnosis of a modality called ETP ALL, a Philadelphia chromosome positive ALL, or a PH-like ALL, which may have a poor prognostic implication. IM21, as I said, if we find this mutation, we will actually be looking at intensifying therapy right from day 1 and looking for hypodiploid cells where we may be actually thinking of intensifying therapy and treating them as high-risk disease. What we have worked on and where it helps us is the precise risk stratification. If we have the age at diagnosis, the initial leukocyte count. So as I said, if you have a leukocyte count that's less than 50,000, then we put you in a standard risk or intermediate risk. But if you are more than 50,000, then you become high risk. Your cell genetics that we've talked about, initial response to treatment. Now, with ALL, we're generally using very old drugs. We're using drugs like steroids, prednisolone or dexamethasone. We're using drugs like vincristine, L-asparaginase, daunorubicin or doxorubicin. And the response to treatment assessment is done. For the first 8 days in a lot of protocols, we only give steroids. And we say that if we can cure the cancer from the blood, if we can remove the cancer from the blood in the first 8 days itself, that is a very good prognostic implication for us. And we know that the cancer is amenable to the treatment lines that we've chosen for you. However, if you don't respond well to steroids, you're a poor prednisolone responder, then that makes you a high-risk patient. We have to intensify treatment for you. So that initial response to treatment as early as day 8, and then at day 15 for some cases, depending on the protocol that you are on, or at the end of induction, which is about day 28 to day 33, becomes a very important part of treatment for us to be able to define and risk stratify and change things. As I said, MRD has evolved, and MRD analysis is now is an intricate part of our treatment right now. It also tells us about treatment adherence and treatment efficacy as well. We've shown, the Western studies have shown that intensifying upfront therapy actually helps to get better cure of disease. And then later on, we can think about de-escalating treatment, which is what will happen with most leukemias. What we plan for them is 6 to 9 months of intensive therapy upfront, and then maintenance therapy, which is just oral therapy for another 1.5 years, so that you can just keep a good control of these disease, the disease as well. So remember that that treatment may be intensive upfront. It may seem very long. We treat for 2 years, but it's intensive therapy just for about 6 to 9 months, and then maintenance therapy for about 1.5 years. What challenges do we face during this time? We know that treatment is long. Whenever you talk to somebody and you tell them that your treatment is going to be for 2 years, then everyone kind of thinks that 2 years out of work, 2 years coming to the hospital repeatedly, that's a very big challenge for a lot of people. But remember, induction, that first 1 month of treatment is very important for us. After 2 years, only 6 to 9 months will be intensive treatment where you keep coming back to the hospital again and again. 1.5 years of treatment is something that will be going on at home, where you really don't need to keep coming back. Or if you come back, it will maybe at 1 month or maybe at 3 months intervals that you're coming back. So a lot of people kind of go back to their old lifestyles then. The children can go back to school at that time. And often one of the challenges that we actually face at that time is that a lot of them forget that they have cancer and they stop taking their medications at that time. So that itself becomes a challenge at that stage. But during those first few days of time, we have a lot of challenges where we want them at this thing. There are things like tumor lysis syndrome. When you have a high tumor burden, you may get what is called tumor lysis syndrome the moment we start treatment. You may get something like an SVC syndrome if you have lymph nodes in your neck or in your chest, and they can block the respiratory or compress the respiratory pathway. You can get an SVC syndrome there, or you could also get your blood vessels compressed by the tumor itself, and that leads to
Dr. Ruchira, sorry to interrupt, for 5 minutes more.
Yeah. So these are challenges, and probably I think, Dr. Juhi, we can probably discuss them as case-based things when we do that.
Yes.
So we will go and discuss this later on, but these are challenges that we face during treatment. Just 2 minutes about advances in treatment. As I said, we've gone way beyond 1967-68, where we started with with total 5 study from St. Jude's. We've gone to using defining our treatment to making it 2 years, using newer drugs like asparaginase, changing the steroids that we've used, using systemic methotrexate, and moving away from radiation therapy as well. So all this has actually helped us to make a paradigm shift in the treatment of ALL and improve our survivals. A lot of our old pediatricians think that ALL still needs radiation, but now we've completely done away with it, except for one small segment of people. And we've realized that this really doesn't now hold true for the present management of ALL patients. So we're not offering any of these radiation. There's one segment that I want to talk about. We get a lot of WhatsApp messages to say that a tablet has actually cured cancer, and now just giving one tablet can cure cancer. It doesn't hold group for the whole group. It holds true only for this particular segment, that's pH positive ALL. Treatment or the discovery of imatinib and addition of imatinib to the treatment protocol has actually changed treatment lines, but it's not just one tablet that works. We still have to offer them a lot of treatment apart from this. But yes, we've moved away from offering bone marrow transplants to these children upfront to giving them imatinib along with their treatment protocol, and then deferring transplants for those who really don't respond or who relapse later on. What does the future hold for us? The future seems very, very bright. We have a lot of targeted therapies that are coming in, but all these modalities, please remember, are for relapse treatments at the moment. We have targeted therapies like rituximab, blinatumomab, inotuzumab, alemtuzumab that can be used for relapse treatments. However, old is still gold for us in terms of the initial treatment that is there. If your child does relapse, there is still hope available that is there. And there's a lot of talk about CAR T cells that is actually being there. Again, this right now is for relapsed patients. So I actually won't go into this. I just wanted to put it out there that there are treatments available even there if the child relapses. So to conclude, we all know that acute lymphoblastic leukemias in children are the commonest cancer, but they have very good cure rates. We have got better understanding about the disease and the biology. We have an appropriate risk stratification for these disease. Old is still old. We still work with a lot of the old medications that were tried way back in 1968, and we still hold that, but novel treatments are coming in, and a lot of treatment depends on shared care. So if the pediatrician is willing to go with us on this journey to treat the child, I'm sure that we'll have more and more children who can, after 10 years, say that they're cured of cancer. So thank you so much for that patient hearing. If there are questions, I'll be more than happy to take them.
Thank you, Dr. Ruchira, for a wonderful session. I'm sure the pediatricians will benefit. Also, as a pediatric oncologist, also I can see in the participants. Now we'll like to go ahead with our pathology expert for today, Dr. Sachin Jain, who will be highlighting the diagnostic aspects of acute lymphoblastic leukemia.
So, thank you, Dr. Juhi. Juhi, screen is visible?
Yes, can you just put it on full screen?
Yeah. It is there?
Yeah. It's not on full screen, but we can see. Yeah, we can see. Please
Now
go
it's
ahead.
full screen?
Yes, yes, please go ahead.
Okay. So excellent talk by Dr. Ruchira. She has covered a few of the diagnostic challenges also. But before starting, I just want to highlight the role of morphology, basically the peripheral smear, because lots of every lab is using the automated hematology analyzers, and if I will go through one city, it is very difficult to get good PS. And we are also, as a clinicians, we are ordering just CBC, not the PS. So PS, I think we have to order quite more, because PS only, unless and until clinicians will not write PS, it will just go many of the times the values of the only hematology analyzers. So, but let me tell you, pediatric hematologist or hematologist, the journey begins with the CBC. And in which direction to move, that direction you will get only through the PS. So like this, just 2 days before, I will get this, just a 1.5-year-old child. And this patient has diagnosed somewhere for leukemia. And I have got actually flow sample for, for the characterization. So if you will see, the total count was 61,000. Platelet count was high, and mainly the instrument was showing 80% lymphocytes and some abnormal cells were there. Here the side scatter was low, and basically to me, by seeing this itself, it doesn't look like acute leukemia. I have seen the slide. So mainly were the mature lymphocytes, but few cells were little large than the normal lymphocytes, and that were having prominent nucleoli. That's why probably someone has called this is a leukemia. And I've asked the clinician, okay, patient is having fever or patient is having very bad cough. Yeah, he has told, yes, patient is having, but why are you asking? Because this probably it's not leukemia, this is simple pertussis. So you treat like pertussis, flow is not required in this. So that's a difference a hematopathologist can make in the practice of the pediatric hematologist. So first important thing is only, as Dr. Ruchira has also told, start with peripheral smear and morphology. So this is, high NC ratio, this morphology of blast, okay, open chromatin might be, this is B-cell ALL. That's a, classical picture of the Burkitt lymphoma. So by PS itself, you will get some clue in which direction we have to move, which panel we have to move on the flow. Like this, if you will see this blast, it's a OR rod. And not only OR rod, if you will see the morphology of OR rod, suppose it's a very thin, slender OR rod, you can predict this will be probably 821 mutation. Because, and that on the flow, it will come, CD19 aberrant in the AML. So morphology still, I still believe the era of molecular NGS and all that thing is going on. But the answers given by the PS, if it's a good morphologist, that's like ocean number of answers by the PS. So this is the AML. Another thing, it's APML, that's acute emergency, acute medical emergency. If we'll get so many faggots or these bilobed cells. So you can straightway, you can think about the APML. So generally in our institute, we will, whenever patient is suspecting leukemia, so we will take basically on the bone marrow, we will take 2 EDTA and 2 heparin samples. One EDTA will be used for flow, heparin will be used for karyotyping or if any other fish testing is required. And another EDTA sample will go for the molecular PCR based test or some NGS based assays if required. These nowadays we are not using it, all special stains, MPO, Sudan black and PAS, because flow is give more quicker answer. So if even sample in our lab, if sample will come before 4 o'clock itself, the same day, we will verbally tell the report to our hematologist or pediatric hematologist. Dr. Ruchira already has told, only aspiration is not enough. Trophine biopsy, many places it's not practiced to take trophine biopsies. Always we have to take trophine biopsies because sometimes it's a focal involvement or if it is metastasis or something, so that you will pick up only on the trophine biopsy. And it's good habit to, if you can make the touch imprints also, when you have taken the trophine biopsy, so that you can get early answer if the bone marrow aspiration is dilute. Next important thing is after the peripheral smear and bone marrow is flow cytometry. So flow cytometry in hematolymphoid neoplasm is used basically in the classification of the disease. We will get the prognosis also. We can predict molecular profiling also in for few mutations. Lots of what Dr. Ruchira has told, potential immunotherapeutic targets also we can identify from flow, and ultimately the MRD monitoring also. So leukemia basically generally either it is AML. So I'm not going into the detail. In the short, I'm just telling. So myeloperoxidase staining or some monocytic marker 64 or something that will tell about the AML part. B cell lineage markers, when you will see initially screens or CD19, cytoplasmic CD79A, CD22, these are the markers for B cell lineage. And cyto CD3 and 7, these are for the T cell lineage. If both markers are coming of myeloid also, or either B or either T, or you are getting B or T markers, then it may be mixed phenotype. If it is not any lineage specific marker, might be it is undifferentiated kind of leukemia. Whenever we are suspecting leukemia, so initial these we are using the acute leukemia orientation tube, that's basically ALOT, or leukemia screening tube. So 34 is for immaturity, that's for leukemia. 19 and 79A, this is for B cell markers. 7 surface 3 and cyto CD3 these are the T cell markers, and cyto MQ is a myeloid marker. This is just a screening tube. Based on these results, we will perform other markers. So BLL classification, pro, common, pre, but most important is the first diagnosis and then characterization. And like we can predict by flow some recurrent genetic abnormalities also, like BCR-ABL1 positive or PH positive ALL. Some aberrant 1333 is coming, or CD25 is coming. So then CD66C, then we can predict it might be BCR-ABL1 positive. If suppose CD15 and NG2 markers are positive, then might be this MLL translocations. And if it is basically low negative CD9 something, then you can predict the 1221. Nowadays by flow, you can find out the diploidy status also, hyperdiploidy or hypodiploidy. BCR-ABL, like a few labs are doing the CRLF2 expression by flow. So you can predict the BCR-ABL like BLL also, because these have a poor prognosis. Similarly, in the T cell ALL, you can reclassify pro, pre, cortical, and mature if it is surface 3 positive. In T cell ALL with the DIM45 position, that's a surface 3 positive, then probably it's a medullary T cell ALL. If 1A will come positive, that's a cortical T cell ALL. We can classify this, and we can characterize the high risk group, that's ETP-ALL, early T precursor ALL. So these ETP-ALL will having the high risk and poor prognosis. How we will detect on flow? That's basically CD1A and 8 negative, and the CD5 expression is quite weak. and any of the myeloid markers or stem cell markers, one of the marker will come positive, then we will think it's a ETPLL. Dr. Ruchira already has told about the immunotherapeutic targets. So in B-cell ALL specifically, we can find out for CD20, it's used quite a long time now. It's rituximab, anti-CD20, and CD22 and CD19. CD19 obviously is a main marker, so that's a blinatumomab. CD22 is inotuzumab, and you have to remember that whenever you are doing CD22, you have to see the surface CD22 positivity, not the cytoplasmic. Cytoplasmic CD22 you don't have to see. If you have to find out the immunotherapeutic targets, you have to see for the surface CD22. Okay, like in TLL, CD38, anti-CD38 daratumab role data is there, CD52 altuzumab data is there. So in TLL also role of immunotherapeutics are coming. So one or two words about measurable residual disease. Already Dr. Ruchira has told that's MRD, basically the early prediction of relapse or intensifying treatment, and to find out the high risks for the potential candidates of transplants. There are a lot of methods to evaluate MRD, but mainly in India right now it is used is the flow, because that's more reasonable, that will give quick result. And nowadays, like in B-cell ALL and T-cell ALL, you don't actually need the initial diagnostic phenotype. All other methods, you need the baseline. Suppose PCR, you need some baseline abnormality, simple. But except the AML, nowadays, if it's a good flow cytometrist, you don't need the diagnostic flow itself. So this already Dr. Ruchira has covered, but the clinical decision thresholds for different MRDs, like BLL, its clinical threshold is 0.01, less than 0.01, TLL less than 0.01, AML is less than 0.1. So what you have to remember when you are sending the MRD sample, it should be the first pool, less than 3 ml, or it's because you have to take only one sample, no follow-up samples or no molecular samples are needed for that. Just one sample you will take, first pull, and less than 2 ml. Depending on the lab, which lab you are sending, EDTA or heparin. Like I have validated my assay with the EDTA thing. Other very important thing for MRD is the transportation. Preferably, it should be processed within 24 hours. But if you are getting samples from remote, it's obviously a little difficult. In that cases, you have to do viability assessment. Viability assessment should be done with the dyes. So just one example, what we are doing basically in MRDs, just to show. So main problem in BMRD is to differentiate the B cell lineage, all the cells, 19 positive. So 19 positive mean cells are, hematogones, plasma cells, mature B cells, and the obviously the blast. So these different type of patterns we will draw on in our the flow software. We will see different patterns like 20 and 10 and some different patterns. But just to tell you, these for the hematogones, like, so if 20 and 10 is a very quite popular plot where you will get the waterfall pattern. So these are hematogones are basically 3 types: hematogones 1, 2, 3. So as the cells will mature towards the to mature B lymphocytes, so 10 expression will go and 20 expression will come. So we know all these expressions, and based on these expression, we will able to find out if these cells are at which maturation stages. Like these bright CD38 positive cells and 34 negative, these are plasma cells. So we know the expressions in different cells, and based on that, we will find out what is the abnormality, and we will find out the abnormal cells. Like if you will see here, these are mature. The green is mature B cells, which are 20 bright, 10 negative, and 34 negative. These are the plasma cells which are 20 negative, 10 negative, and these 38 bright. But these are the abnormal population cell. This is the red that's highlighted. That's a 45 negative, 10 very bright, 38 is little dim, and this 73 is coming positive. 73 and 304, these will not come in the hematogone. So based on these patterns on different markers, leukemia-associated immunophenotypic markers approach or different than normal approach, we will find the abnormal cells. This is another case like here, previously case 10 was very bright in the 19 positive population, but here it's again 45 negative, but this is very, 10 is dim, but here clear cut 73 is positive. So this is 138 is negative. This one other case of some MRD positive. In the one last one or two things for the future, that's a digital hematopathology that also has a role, because we have evaluated these three instruments in our lab. That's a CellaVision, that's a SIGTUPL, and the Morphle. These, based on these, you can see all the cells, and you can give the diagnosis from the remote itself. You have to put the system at remote areas. Like this is one of the picture where in the patient was sitting at the Gorakhpur, and this turned out to be APML. We have seen the slide when we were evaluating, and we have given the diagnosis, and patient has been saved. So thanks for your kind attention. Just a quick thing. Any questions I think we can take in the end?
Yeah, thank you, Dr. Sachin, for such a comprehensive talk. I think both the talks given by the experts were so comprehensive that most of the questions that I put up for the panel are answered. So with that, I would like to start with the case-based scenarios. Just share my screen. Yeah, is my screen visible?
No, not yet.
Yeah. Oops.
Dr. Sachin, would you stop sharing?
Ankita, can you help?
Yeah, just
Yeah.
is my screen
Yes. Wait, I'm closing source
just
screen
close it.
presentation because okay.
Yeah.
Now you can share. Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yeah. So after the detailed discussion on the clinical and pathological aspects of ALL, I'll just go through some cases. So the first case is a 5-year-old boy. He presented with high-grade fever since 3 weeks, bilateral neck swellings, which were rapidly progressing since 2 weeks. Mother also noticed that the child had mouth breathing at night since 1 week, and there was a significant history of loss of appetite. On examination, the child was febrile, he had a temperature of 101, the heart rate was 110, other vitals were stable, and oral cavity examination was normal. There was significant cervical lymphadenopathy, bilateral, firm 3/2 centimeters, and the air entry was decreased on the left side. And the child did feel had orthopnea. I mean, he was better when he sat down, but he had a lot of noisy breathing and complaints in respiration, difficult respiration, while he would lie down on the hospital bed. On examination, there was no hepatosplenomegaly, and normal heart sounds were heard in the CVS examination. A CBC was done, and it showed a rather normal CBC with a manual differential count of neutrophils 40%, lymphocytes 45%, and 5% monocytes, and the peripheral smear and biochemistry examination were normal. Because of these complaints, the child underwent actually multiple X-rays, of which we can see that it showed mediastinal widening in the upper X-ray. And also, the lower one is a rotated film, but you can see that the CP angle on the left side is blunt and looks like a pleural effusion. I would just request the participants if they could mute themselves. Yeah, and a CT scan was done, which you can see that showed an anterior mediastinal mass, which is quite significant, with a pericardial effusion and also the black curved arrow showing a pleural effusion. So there was significant cervical lymphadenopathy in this child with anterior mediastinal mass, with left pleural effusion and pericardial effusion. So my questions to the panel, to Dr. Ruchira, would be that at this point of time, what would be the differential diagnosis in your mind, and how would you like to evaluate this child further?
Thanks, Juhi. So the anterior mediastinal masses for me generally kind of flag out a lymphoma. I'm very worried that this could be a lymphoma. It could also be a germ cell tumor. It could be a teratoma or a immature germ cell tumor as well. But for me, when you talk about the lymph nodes in the neck and all, I'm
Yeah.
thinking in terms of lymphoma, which could also be a lymphoma leukemia kind of a pathology as well. So that's where I'm looking at that. In rare cases, this could be a thymoma as well, but the child's too young for a thymoma. Or could be some congenital cysts or malformations, but they are very low down on my differential right now. So I'm thinking lymphoma leukemia versus a germ cell tumor or some kind of an immature yolk sac or a teratoma kind of a picture. Yeah, Dr. Aisha, I agree with you. We're thinking more in terms of T cell ALL or a lymphoma. How would we evaluate this child? So blood tests would be the first thing I would ask for. I would ask for a CBC with a peripheral smear and ask Dr. Sachin to have a good look at that. I'll be also asking for an LDH, and LDH is an indirect marker to tell me what is there's this rapid cell proliferation happening. The LDH, a uric acid, and the renal parameters that are there as well. So look at creatinine as well. To get a biopsy would be the imperatives of trying to find out how can I establish a diagnosis. If Dr. Sachin can tell me that he can see a good number of blasts on the peripheral smear itself, I may not need any other evaluation to be done. But otherwise, I would look at maybe looking at that pleural fluid that you were talking about. There's that pleural effusion. So tap the pleural effusion and see if we can get cells out of that. Or even look at doing an excision biopsy under local anesthesia for the lymph nodes, or a bone marrow aspiration as well to look at getting a diagnosis from those areas. Rather, I mean, something that is least invasive for us right now with the history of having orthopnea.
All right. And I think the mediastinal mass, along with an effusion, as you said, like quite narrows it down, as we have seen, to as you said, lymphoma leukemia more than the other solid tumors.
Yeah.
So, as you said, that yes, this child would require diagnostic tests, and as these tests would be invasive because we have seen there is a mediastinal mass also. So, what are the challenges you generally face in giving general anesthesia for a small child for invasive procedures? And how do you assess that should I give, should not give? What is the risk?
So the mediastinal mass is a very big kind of flag for us. We generally don't want to offer minimal like sedation procedures for them. The reason being that if we do sedate them, we will lose control of the airway with them, and we may not be able to revive them, and they may need intubation, and intubation may be per se very difficult. Also, even if you can intubate, you may not be able to ventilate them properly because the smaller airways may be actually compressed at that time. So general anesthesia has to be done by a specialist who's confident that they'll be able to both intubate and ventilate properly, because those two, both modalities, you may be able to intubate, you may be able to get your endotracheal tube in, but you may not be able to give proper ventilation to this child. So that is where it has to be assessed by a good anesthetist with that. We, on the other hand, would try and do things under local anesthesia if we can, or try and use like a pleural aspiration or something else to try and gain a diagnosis out there.
Yeah. So I'd also like to highlight that there are subtle signs, like when you do a CT scan, as you can see, we generally look at the tracheal diameter, as in the amount of trachea. You can see if less than 50% is not seen, if there's a compression of more than 50% of the tracheal lumen, then you know that this child is a high risk when you would give a general anesthesia. And also CT scans and all these procedures should not be done under sedation in such children. And many of times you cannot do it in a supine position, then you can use a lateral or prone position to do a CT. So Dr. Sachin, as Dr. Ruchira has already highlighted, but if we could go through it again, like what samples are enough in this patient to establish a diagnosis for you? And as you know, he has a mediastinal mass, so we would like to go from the least invasive test, like the test which would give sample by least invasive method.
Yeah. Sachin, you're mute.
Yeah. Now it's clear?
Hello. Yeah, we can hear you.
So as you have told, the CBC is normal and there are no blasts. But if you are there, so we can take effusion samples, and actually before sending, it has to be 2 or things you have to keep in mind. Flow cytometry can be done with fluids like CSF, ascitic fluid, pleural fluid, or cardiac fluids, the pericardial fluid, that can be done. But only the caveat or the thing you have to keep in mind, the cells in the fluid will degenerate very fast. So ideally, you have to choose the lab which is nearby your practice area, and the sample should reach to the lab quickly, and sample has to be processed within 4 or 5 hours for flow cytometry if it has to be done. So that's one challenge in fluids. But yeah, and other thing, you have to see the lab which you are sending. So they have well established protocol for fluids or not, because many of the labs are not standardized and validated their assays for fluids. So some precautions you have to take when you are using the fluids, because cells are more fragile comparatively. But you can use the, in this case, if you will ask me non-invasive thing, so that's first you can use any of the effusion sample.
Okay. And Dr. Sachin, suppose if the peripheral smear is sent to you and it shows blast, so is peripheral blood enough for establishing a diagnosis of leukemia in this patient?
That depends. Like this kind of case, peripheral blood for characterization of blast, obviously it can be done. For the lymphoid, it is usually good, because even if you have characterized 5 or 6 kind of blast, whether it is B or T, so it is probably B lymphoblastic leukemia lymphoma or T lymphoblastic leukemia lymphoma. So for lymphoid, I think characterize the blast on flow and diagnose. But on the myeloid, it's a little tricky, because the percentage of myeloblast is an important thing. Because if it is less than 20% blast, then it is MDS, or otherwise it is towards the myeloid. And if it is some some other kind of myeloproliferative neoplasm, you have less than 20% blast. So then in that cases, the bone marrow is required definitely. If it is more than 20% blast in then no issues, you can characterize it. Other thing is, when you are having the less percentage of blast, so sometimes because nowadays you want to genotype patient leukemia, so in that's a little tricky if you are having 3 or 4% blast, because that can give you the false negative result for the molecular PCRs. So that you have to keep in mind. For if it is blast are less than 10% or 5%, some that kind of thing.
All right, thank you. So this patient, as we all discussed, underwent diagnostic thoracosynthesis and pleural fluid morphology was sent. So Dr. Sachin, any comment on the morphology?
So these are looking like monomorphic population of cells. So as we are predicting in geometry also, lymph node, effusions and mediastinal mass. So probably it is kind of might be lymphoblastic leukemia lymphoma, but we have to obviously do the flow cytometry.
Yeah, so the pleural fluid was sent for flow, and this is the report. So what would be your interpretation, Dr. Sachin?
So if we will see first most important thing, we have to find out that's a mature or immature. So for mature or immature, you have to see one thing is 45. CD45 is dim or CD45 is bright, like on the lymphocyte. So CD45 is dim. So and any other immaturity markers. So immaturity markers in this, I'm seeing the 34, but 34 is negative, but 45 is dim. So that is giving clue towards the leukemia rather than lymphoma. Now, if you will talk about the B cell markers, so 20 and 19 is negative. However, cyto79 is looking dim to negative, but 20 and 19 is negative. Generally, the cyto79 is sometimes will come aberrant in few cases, but 19 is negative and 20 is also negative. So this is not, we are not dealing with the B cell. Myeloid markers are also negative. I think this is what is written AMPO. This is probably cytoplasmic myeloperoxidase. This one and 64, 13, 33, all myeloid markers are also negative. So that is ruled out. CD7 is bright. So generally CD7 is bright and surface 3 is dim to negative and cyto CD3 is positive. So that is towards the T cell ALL. So 45 is dim. And another thing is, if you are thinking in terms of T cell lymphoid malignancy and surface 3 is negative, okay, and cyto-CD3 is positive. So that's little bit confirmed that you are dealing with the leukemia, T-cell lymphoblastic leukemia or T-cell ALL. So by seeing these 7 bright cyto-CD3 positive and some other markers are there, 5 is moderate, 1 is subset. So it's look like T-cell leukemia lymphoma.
All right. So yes, diagnosis was TALL, and the patient did undergo bone marrow studies, which showed that morphologically they were 30% blast, so it fitted into TALL. So Dr. Ruchira, how would you stabilize this patient initially, and how would you initially start treatment for this patient?
Steroids form the basis of our treatment initially. We give them steroids up front, and maybe only steroids, or maybe a low cytoreductive therapy with vincristine, and a low dose cyclophosphamide may also sometimes work, but generally only steroids for a T-cell ALL will also be good enough. I probably would defer the CSF examination for maybe after a week, because I don't want to sedate the child right now, and therefore we'll do the full staging later on. What I would monitor would be for tumor lysis syndrome. So give them good hydration. Make sure that you don't have necklines, because that may be difficult for them. So have peripheral cannulas for them. Work with good hydration. Give them urate oxidase inhibitors, so maybe allopurinol or rasburicase, depending on what is available, and treating with steroids and monitoring for tumor lysis, which means that we're monitoring for a raise in creatinine, a decrease in potassium, a decrease in your calcium as well. Strict input-output balances would be very important for these kids, because of the increased fluid and hydration that we're giving them, they can sometimes land up with cardiac failure as well, because their chest and mediastinum is already compromised.
Yeah. All right. So with that, I'll move on to the second case. So this is an 8-year-old girl with V acute lymphoblastic leukemia on induction chemotherapy, day 11 of the therapy, and she presented with 1 episode of vomiting followed by generalized tonic-clonic seizure. When she was seen in the emergency department, her GCS was 12/15. She was febrile. Vitals were fine with a BP of 124/86, which was more than 99 percentile for age, and the saturation was normal. CNS examination wise, she was in a post-ictal state, so she was drowsy, but otherwise the CNS examination did not yield anything, and the other system examinations was also normal. So Dr. Ruchira, what are the causes of seizure in a child on ALL induction chemotherapy?
So if it's right up front and I'm dealing with a child who has hyperleukocytosis, the hyperleukocytosis by itself can be a cause for seizures because of sluggish blood flow that is there. But when you've started treatment and then it comes in, we generally think it's because of the drugs that we have given them. Both steroids, be it dexamethasone or prednisolone, can cause hypertension, and hypertension can cause seizures, because there's an entity called posterior reversible encephalopathy syndrome, where you have a kind of a hypertensive crisis that is happening, and that can result in it. Asparaginase that we give our children, L-asparaginase, Lunase, whatever L-asparaginase form that you're giving, whether it's E. coli asparaginase or PEG asparaginase, can cause cerebral venous thrombosis in our patients, and that can also cause seizures in our patients as well. So steroids, asparaginase treatment, upfront seizures, and because we're doing intrathecals as well, a few of our children can actually get methotrexate encephalopathy. That's a very small population of our children who can do that, but yes, that may be something that we may have to watch out for. When you're dealing with tumor lysis syndrome upfront, because of the electrolyte imbalances that happen at that time, some of our children can also land up with seizures at that time as well. But in our child, I'll probably be looking at PRES, and especially with that history of hypertension that is there, I'm thinking in terms of PRES, whether it is asparaginase or whether it's steroids, I don't know the answer to that.
All right. So the child was stabilized by giving a loading dose of injection levetiracetam and sublingual nifedipine. The CBC biochemistry and electrolytes, as you mentioned, were normal, and MRI brain was done. So the MRI, as you can see, revealed in the T1 hypo and T2 hyperintensities, particularly focusing on the parieto-occipital area. and also showing hyper enhancement on the diffusion weighted images. So, Dr. Ruchira, what is your clinical radiological diagnosis for this child? As you already mentioned, what is the pathophysiology of PRES and how will you manage this case?
So this looks like this is classical. The MRI picture is classical for posterior reversible encephalopathy. The two drugs that we generally blame would be either prednisolone, that's steroids, prednisolone or dexamethasone, and we also think about asparaginase in our patients. In our bone marrow transplant patients, we often see that with cyclosporin as well. And renal transplant patients also, you may sometimes see the same picture that is there. In terms of pathophysiology and etiology, usually the hypertension that's leading to vasoconstriction may be one of the pathophysiologic mechanisms that is proposed. But we also think about endothelial damage that may be occurring in our patients because of the drugs that we are giving to them. So with asparaginase, we think more of endothelial damage, or maybe some kind of a very small thrombosis that is occurring, causing the vasoconstriction that is happening. So these are the two main hypotheses, are either hypertension or endothelial damage. That is the thing. In terms of management, there's a doubt about whether we should be using levetiracetam or not. Our neurologist friends generally don't want us to use levetiracetam unless they're repeated seizures. They think if you can take off the offending drug, then yes, it will work. However, in induction, it's very difficult to take off steroids. So we have to kind of take that balance in, because we want to give them the steroids. Steroids are being very effective. With asparaginase, if you've given asparaginase, you can do a trial of asparaginase in subsequent protocols that you subsequent later on in the field. Again, most studies say you can try it, but we have to be brave enough to do that.
Yeah. So I think case 3 is something which we have already discussed. So the any child, like the child one who had undergone were diagnosed TALL and underwent a 4-drug induction chemotherapy. So this child was given the induction chemotherapy. So my question is, as you had already mentioned in your talk, like what are the various ways you can assess treatment response? As we know, different protocols have day 8, day 15, day 35 assessments, and what is their significance?
So the earliest response for us is a day 8 blood response. We want to see a blast count. If there is a blast count present, we want to see that the blast count should decrease to less than 1000 per ml by day 8 on the peripheral smear itself, which is a very good indicator to tell us whether this is a good prednisolone responder or a bad prednisolone responder. Good prednisolone responders, we continue on the same protocol that we've chosen, whether it's standard risk or intermediate risk. Whereas those that are standard or intermediate risk but have a poor prednisolone response, we would like to increase that treatment to shift them to a high risk arm for these children. Then we do the MRD assessment. MRD assessments initially were done at day 33, which was considered time point 1, and then at the end of induction, which is or consolidation, which is time point 2, was around day 79. Now the theory is that if you can show that they're MRD negative earlier, so using a day 15 response to MRD, or even some protocols are actually looking at day 8 as well. If you can show early MRD negativity, you know that they will be better responders, and therefore you can think about decreasing their therapy as well. With the BFM protocol that we are using, we do a day 15 MRD assessment as the protocol suggests, but we're not changing our treatment based on that right now. So for us, the day 33, that's the end of induction 1A protocol, and the time point 2 protocol becomes important for us.
All right. So the child did undergo a post-induction bone marrow morphology and flow cytometry. And as you can see that the morphology showed normocellular marrow with 3% blast, and the flow cytometry showed that there was no evidence of any aberrant T cells, so negative for residual disease. So Dr. Sachin, you already highlighted this. If you could just emphasize, like what are the various methods we are currently using, and what would you prefer?
So MRD is basically, as Dr. Ruchira has told in her talk, initially it was basically minimal residual disease, but now the redefined the term is measurable residual disease. So whenever there are many methods for doing MRD, one is, but the sensitivity and specificity is different for different methods. like MRD is a measurable residual disease, so that can be done on the, on the bone marrow also. But bone marrow, the morphological remission criteria is 5%. If it is more than 5%, so it is probably residual disease. But if it is less than 5%, it's in morphological remission. But suppose we will take a case of BMRD, so and you are getting 3 or 4% blast. So it's very difficult to get on morphology in BLL case. This is can be hematogones also. So 3-4%, it's very difficult to get on the morphology. These are hematogones or these are the lymphoblasts. So that's why the role of obviously MRD has come, and where you can characterize these small number of abnormal cells. One of the preferred method is flow cytometry, but other methods are also available by the PCR method. Suppose if you are having some known pH positive B cell ALL, so in that case you can track the in BLL generally it's P190 transcript, so you can find out that one. But in that cases, you have to find out at the diagnostic time this is BCR-ABL positive. Particular mutation is positive at the diagnostic time. You have to follow up that. Like in AML, if it is 821, you will follow the 821. So diagnostic baseline workup should be strong for all other methods, whether it is FISH, whether it is NGS, whether it is or PCR based assays, anything. So that is very essential. So that's why the flow cytometry MRD is more preferred. That is will give quick answer, and its sensitivity now is comparison to almost similar to the PCR. If you will find out the lab which are acquiring more events, because as you are acquiring more events in the MRD, your sensitivity of the MRD assay will go. Like in our lab, we are acquiring almost 10 million events. So generally the labs will acquire 1 or 2 million events. So our sensitivity is 1 log more. So my idea is if you are your clinical threshold is 0.01. So my idea is in my lab the sensitivity should be 0.001, so that I should be confident if in giving 0.001. But when I will be confident when I will acquiring more and more events. There are practical challenges around that. So a lot of validation and standardization has to be done. But for clinician, it is better, because if your clinical threshold is 0.01 and I am giving positivity at 0.001, so you can take decision easily, and you should be, I think you must be more confident on the lab. So whenever anyone is choosing the lab for MRD assays, just go through their limit of sensitivity and these kind of thing. If someone say we are acquiring 50,000 event or 1 million events and they are achieving 0.001 sensitivity, it's quite difficult, because if you are acquiring 1 million events and you are seeing 0.001 sensitivity you are achieving, it means only 10 abnormal cells you are finding out. So to finding out the 10 abnormal cells and 1 million events, it's a little tricky thing, because that's just a 10 dots. But if you will basically will acquire 10 million, so 100 dots. So 10 dots and 100 dots will make a lot of difference. So whole idea is the more events you will acquire, the sensitivity will be more. So and I think somebody asking also, Dr. Kaushik was asking.
Yeah.
Dr. Kaushik was asking that question. So as a clinician, I would always ask for an MRD. We've got 6% blasts, and we found that all 6% were hematogones also, or even in 3 to 4% blasts where you think they're in morphological remission, you get an MRD positivity as well. So MRD is really important for us as a clinician.
And just to highlight, means I have reported in the pediatric cases specifically, I have reported till 25 to 30% also hematogones, but it's an MRD is negative. So I think whether in BMRD, whether you are getting 6% or 7%, BMRD has to be done.
All right. And I think we should stress on the point that the baseline sample and the MRD assessment post-induction should go to the same hematopathologist.
yeah, that is
And
easy.
because they have to compare the baseline clones and all those things, so it should go, because many a times the marrow is done somewhere else, as Dr. Ruchira mentioned, and then the pediatrician refers to the pediatric oncologist. So it becomes very difficult. Like post-induction MRD should be done with the same lab. There is another question. If Dr. Sachin, you could take that. Is there any chance of developing BCR-ABL fusion in long-standing ALL case? Is there any morphology which suggests BCR positivity?
The morphology, is there any morphology suggesting the BCR positivity is not quite common, but yeah, if the morphologically you are getting the coarse granules in the in the blast, sometimes you can just think about it can be BCR ABL positive, pH positive, but it's not unless and until it will be BCR ABL positive.
On flow, is there any signs which would tell you that?
Flow generally, if basically you are getting aberrant 13, aberrant 33, or you are getting aberrant 66C, so that is prediction that our chances this B cell ALL is going to be pH positive ALL. So you can predict, but obviously it has to be confirmed with the BCR ABL thing only. And another thing, BCR ABL fusion, is there chance of developing? So it's quite less chance, because if it is at the diagnostic point, if it is negative, so probably it is going to be negative. But yeah, rare scenarios, some different clone can develop later on, but that not because of the therapy. That's might be some different clone is developing, which is now evolving of BCR-ABL1. And another thing you have to keep whenever you are sending BCR-ABL, so like CML. So CML, the BCR-ABL is different, and this generally B cell ALL BCR-ABL is different. Both transcripts are different. So you have to make sure wherever you are sending, so they are able to find out the P190 type of transcript, because otherwise it can be false negative. So if you are strongly predicting this, in that cases you can reconfirm with the BCR-ABL fish, because that will be definitely positive.
All right. So that answers all the questions in the chat box. I mean, it was a wonderful session. Thank you, Dr. Ruchira and Dr. Sachin. Thank you, Dr. Monica, for getting all of us together. I'm sure that all the participants have gained a lot from this session. I mean, on the clinical aspects as well as the diagnostic pathology. Thank you so much.
I want
It
to
was a
thank
wonderful
Dr.
session.
Ayesha in the audience.
Yeah, she's been very
quite
active.
interactive. Yeah. Thank you, Dr. Ayesha, for listening to us.
Yeah, you
Thank you so
answered
much,
all the
ma'am. It was such a
questions
pleasure
before
to
us.
listen to all of you.
Any other questions from any other?
Yeah, you have any questions, Dr. Ayesha?
No, ma'am. Thank you so much. It was such an interactive session. I really enjoyed it and learned a lot from it. Thank you so much once again.
Thank you.
Thank you everyone. Thanks, Dr. Ruchira. Thanks,
Yes.
Dr. Julie.
Thank you.
Thank you. Thank you all of you. Thank you, and have a good day.
night.
And thank you, Dr.
Good night.
Monica.
Thank
connect
you.
Yeah.
with
Bye.
us.
Thank you, Dr.
Thank you
so much. Yeah.
Bye.
Thank you,
Bye.
everyone. Thank you, everyone, for sharing your valuable insights. And we hope to meet you again on this platform very soon. So with all your permission, we'll continue the session over here.
Thank you.
Thank you.
Bye-bye.